Hello, everyone. Thanks so much for joining us this Wednesday afternoon. We are here to talk about obsessive-compulsive disorder, OCD, how it appears in kids and what we can do about it. I know some people are still filtering in, but I think we'll go ahead and get started. So, I am Mandi White-Ajmani. I am the owner of Small Brooklyn Psychology. We are a group psychology practice at Industry City in Brooklyn, New York, where we offer therapy and neuropsychological assessment to people of all ages, all backgrounds, all psychological concerns. You can see all of our lovely clinicians at the in a row along the bottom. I love seeing everybody's faces, but that's me, Natasha Brown, Dr. Rebecca Abbott-Sinclair, who is here joining us today, is going to lead this webinar. Dr. Sam Janit, Maddie Lawler, Dr. Nav Gill, Cecilia Barbosa, Dr. Megan Moxie, Dr. Caroline Carberry, Dr. Olga Fuller, Dr. Amira Hanna, Dr. Danielle DeFilippo. We got a lovely lineup. We all have experience working with people across the lifespan, but we have special training and experience to work with children and parents using evidence-based assessment and treatment. Now, one of my goals at Small Brooklyn has always been to be a resource to the community. So whether you work with us directly or not, we do what we can to provide mental health knowledge, suggestions, and connections to providers. One of the ways that we do this is by leading these webinars, just so we can get all of the word out as much as possible about the things that we know. We really love to share our expertise, and we do this with our longtime partner, Park Slope Parents. So they are really the OGs in getting information out to parents in Brooklyn. So if you are a member, awesome. And if you're joining us as a non-member, consider joining, even if you live somewhere other than Brooklyn, because there's just so much great information that's shared. We have developed a lot of webinars in the past couple of years through a whole lot of different areas of psychology, from tips on managing behavior at home and in a classroom to what a neuropsychological evaluation is and what it might do for you, to things like what are exceptional children, twice exceptional children? How do you help girls with ADHD? What does marijuana use really do for the teenage brain? There's lots of those different topics and more, and they're all available for free on our website at smallbrooklyn.com/services/talks. So now we're going to turn to obsessive compulsive disorder, or OCD, and how it looks in kids. So I'm joined today by Dr. Rebecca Abbott-Sinclair, who is our director of therapy and has been doing therapy for kids, teens, adults for 10 years at this point. Is that right?
That sounds right. I've lost count.
Maybe
It's a
more,
long
probably
time.
more. It might be in your bio, which I'm about to read. But she's treated many children, teens, and adults with great outcomes. So, Rebecca, Abbott-Sinclair is a clinical psychologist with extensive training in treatments for psychological disorders across the lifespan, including cognitive behavioral therapy, just CBT, dialectical behavior therapy, DBT, and acceptance and commitment therapy, just ACT, for symptoms of depression, suicidality, self-harm, interpersonal difficulties, generalized and social anxiety, panic, school refusal, and trauma. But she has extra expertise and training in specialty treatments like exposure and response prevention for OCD, which is a big part of what we're going to be talking about today, as well as things like habit reversal training for trichotillomania and other body-focused repetitive behaviors, supportive parenting for anxious childhood emotions, SPACE, which is also going to come up today, which is a parenting treatment for child anxiety, which we love. It is super effective. Parent-child interaction therapy for things like selective mutism and behavior issues, parent management training. Becca has a PhD in clinical child psychology from St. John's University. She's trained at Bellevue, Child Study Center at NYU, the Child and Family Institute. She was the director of psychological services at Brooklyn Mines for several years. And so now she is here with us at Small Brooklyn. We're very happy to have her. And when she is not doing all these amazing therapy services, she loves baking, cooking, watching trashy Netflix shows, which we talk about, and all the NYT, New York Times games. She has two small kids and a fur baby, a Bichon poodle named Milo. So, Becca, take it away. You're going to talk for a while, and then I'm going to come back at the end for a question and answer. So, if you have questions during this webinar, type them to me in the Q&A box, and I will be monitoring them. And then we will try and get to as many of them as we can at the end. We will also be sending this recording and the slides to you at the end, so don't feel like you have to frantically take notes during any of it. Take it away, Becca.
Thanks for the intro. Thanks for mentioning Milo, my first baby, my fur baby. He gets forgotten for the newer babies all the time. So I appreciate it. Thanks for that
Yeah.
great introduction. And thank you guys all for being here today. Um, you kind of gave my intro away. So I'm going to go right into my next slide and talk about what we're going to try and do here today. I imagine for a lot of our audience members, you're here because you want to know how to help a kiddo who might be suffering from OCD. And like the old saying says, knowledge is power. One of the biggest takeaways you can have from this is an understanding of what is OCD and how it works. Understanding it demystifies it, helps us be able to talk about it, helps us be able to interrupt it, helps us be able to manage it. So we're going to do a lot about kind of learning about OCD and different presentations and what are the threads that connect them. And we're also going to talk about some specific tools and some specific interventions. We're going to go over what kind of therapy interventions are really effective for OCD and also some specific strategies for home. That being said, any specific strategies for home, really encourage working with an OCD provider to make sure that you're being consistent with anything a kiddo might be working with and what you might be doing at home. And I want to save a lot of time for questions. I can talk really fast. I'll try to keep that up actually, so that we can have time for lots of questions. All right, so what is OCD? So it's a mental health disorder, and we're going to kind of break it down here. Obsessions, that's our O. Intrusive, unwanted thoughts, urges, or images that cause distress to the person. And then compulsions. So compulsions are behaviors that a person feels compelled to do, compulsion, compel, right? That are done to reduce the anxiety of an obsessive or intrusive thought. Sometimes it's done until it feels just right or until a certain number of times, but the person feels compelled to do it in a repetitive way in some way. One of the things I always like to talk about, it's not just cleanliness and orderliness. It's not just the pop culture presentation of OCD. It's not just somebody who needs to wash their hands all the time. It's not somebody who just needs to organize all the time. What we're looking at when we're talking about the D, disorder, because everybody has intrusive thoughts. Everybody has some behaviors that they feel like they have to do until it feels just right. But we want to also think about the D, disorder. Is it causing significant distress? Is it interfering with functioning? Is it decreasing the ability to function in ways a person needs to function? For adults, work, relationships, all of that. For kids, family, relationships, school. And we want to look at time consumed by it. We want to think about it in terms of how it's interfering, not just because of distress felt, but how much time is it taking up for a person? Prevalence. So about 1 in 100 people, so that's 3 million people in the US have OCD, and approximately 1 in 200 kiddos have OCD. So it has a pretty high prevalence rate. And we also know is that it most often shows up between the ages of 8 to 12 years old. However, it can show up much younger. I have not treated anyone this young, but I have read papers and gone to talks about it showing up as young as 3 years old. When it gets younger, it's pretty hard to differentiate because 3-year-olds have some repetitive behaviors just from the get-go, but it can show up younger and sometimes it can show up older. But what we also want to think about is the time between the symptoms showing up and diagnosis and getting effective treatment. For adults, the average range for between showing for a symptom and actually getting a diagnosis and effective treatment is between 14 and 17 years. That stat has gone up since I started doing talks like this. It used to be 11 years. It's going up. And so what we think about with that is that a lot of people are underdiagnosed or it's mistaken for a different diagnosis when they're younger. And when they're adults, something sparks, something happens that helps them recognize that it might not just be anxiety or just a quirk or just this or just that it's actually OCD. And for kids, that time's a little bit shorter, which is a good thing, but it's still on average 2.5 years between symptoms showing up before they're getting proper treatment. And again, that's because OCD can really mask as other things, or somebody could say, oh, it's just a quirk, or, oh, they'll just get over it, they'll grow up, all of that. And we want to be thoughtful in terms of what might be OCD because a lot of great intervention is out there. I tell kids all the time and I tell parents all the time that when, you get the diagnosis, sometimes it can be scary. Sometimes people are scared of the stigma. One, a lot of sufferers from OCD feel really relieved in getting the diagnosis, knowing that they're not alone, knowing that there is a label that explains it, that other people have had the feeling that they're feeling. A lot of it's private, so a lot of times it's very isolating to think that you're the only person having this kind of experience or these kinds of thoughts or these kinds of behaviors. And two, we have really effective treatment for it. And that's a great thing. And that's really, really good news, right? Here we have here that about 70% of children and adolescents who receive our evidence-based treatments for OCDs are going to benefit. They're going to have symptom reduction. So getting a little bit more specific, obsessions. We all like to use the word obsession in very casual use, right? I'm so obsessed with this. It is not just being preoccupied with a specific topic or something like that. Most people have occasional unwanted intrusive thoughts, but obsessions are beyond that. Obsessions get stuck. So it's not just like, oh, I'm obsessed with this, I'm so OCD. No, obsessions are these intrusive thoughts that get really stuck for people that people don't want to have, but they just keep coming up over and over. And the obsessions generally are marked by doubt and by distress. So what's the difference between having an occasional intrusive thought and anxiety and having an obsession within the OCD framework? Everybody has intrusive thoughts. We all have intrusive thoughts. Our brains are always going. They're always coming up with new, fun, creative, sometimes scary ideas. But a person who is not suffering from OCD, or even somebody who's suffering from OCD, but their OCD might not latch onto one specific content area, can move on. They can say, yeah, that's kind of a weird thought. And they just move on with their day and they don't give it a second thought. But for someone with OCD, the thought gets stuck. And when the thought comes up, they experience this extreme anxiety, and the thought and the behavior that follows from it causes a decrease in their functioning in some way. Ah, sorry, I just accidentally got out of my window. Give me 1 second, guys. Okay, I'm back. Technology is fun. Okay. So, like I've been saying, and I like to emphasize this because I think it really helps normalize and destigmatize. People with and without OCD experience intrusive thoughts. We're at Park Slope Parents, we're in Brooklyn, people take the subway. Everybody who has taken the subway has had an intrusive thought while on the subway platform about something scary happening right there. And that's because our brains are trying to keep us safe. And so it's saying, ooh, this might happen. If you don't have OCD, if you're OCD, it does not latch onto that idea, you can say, that probably won't happen, and you can move on with your day. But for a person with OCD, this causes extreme distress, and they try to suppress the thought or think, oh my gosh, that must mean something really, really bad might happen because I had the thought. I got to get rid of it. I got to keep myself safe. And that attempt to neutralize or reduce the anxiety with the thought for a person with OCD causes a rebound effect. It makes the thought get more stuck. Right? For a lot of us, if you say, oh, well, what if this bad thing happens on the subway? You say, that's probably not going to happen. Oh, okay, I'm cool. But for a person with OCD, okay, that's probably not going to happen. But what if it does? But what if it does? And that's the rebound effect of trying to suppress or neutralize the thought. Oh, my graphic got cut off. That's okay. All right. So for an example of this, what I'd like us all to do is take a few seconds and don't think about this white bear. Less audience participation to actually know what's happening, but I'm guessing most people here are thinking about the white bear because that's what happens. When we tell our brain, don't think about it, the brain goes, oh, that must be a dangerous thought if I'm not supposed to think about it. If it's a dangerous thought, I should look out for any signs that I might be thinking about it. Oh, now I'm thinking about it. And for people with OCD, this cycle happens to them all the time, or a huge majority of the time, I should say. So in terms of how this shows up, there's a couple of common areas that it tends to show up with, but OCD can really latch onto anything that's kind of scary or unpleasant, and a lot of that is really socially influenced. And what it means by that is influenced by values in a family or larger culture, whether the city you're in, the country you're in, religion, group, anything, that it can really be socially influenced. But there are some common ones that come up a lot for kids. Germs contamination. That's our pop culture thought of it. And it's true. A lot of kids with OCD will have obsessions about contamination, sickness. Sometimes they even have emotional contamination. I'm worried if I have a bad feeling while looking at this book, and now I can't look at this book anymore because I'm worried about going back to that bad feeling. So contamination can mean lots and lots of different things. Perfectionism. Perfectionism does not always mean OCD, but it can mean OCD, particularly if the person knows that the perfectionism is unreasonable, but they still feel like they just have to do it. A really common one, kids, is the just right OCD, needing things to be just a certain way, just right. They can't really explain exactly what it is, but it's that compulsion to make it all just feel right in some way. A really common area that isn't as well known in OCD is worries about harm coming to oneself or others. Not just a general worry of, I wonder if bad things might happen, but getting really stuck in the idea of worries about harm to self or others, particularly in being responsible for harm in some way. Sometimes it can get stuck on worries about loss of control of one's own actions, worried about acting impulsively or acting without thinking or doing something that would really be against the person values. Another big one that doesn't get mentioned a lot because it's taboo is really just unwanted or taboo topics for kids. And because obsessions latch onto fear and latch onto feared thoughts, particularly if we say like, oh, no, 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 that's a bad thought. I can't have it. We have that rebound effect. The things that are taboo in a given culture can be a lot of fodder for OCD. And that kind of leads into this last really big area, which is moral scrupulosity, which I love to say. It's such a fun saying. But it's basically this obsession of, am I bad? Am I good or bad? Am I evil? Particularly when it ties into the thoughts about harm or taboo topics can come up quite a bit. Now, what are compulsions? Compulsions are behaviors that a person is driven to do repeatedly in response to obsession or in response to a rule that OCD might have made for it. The rituals are done to reduce the anxiety, at least that's what they're trying to do with it, or to prevent bad things from happening, to prevent those what-ifs from occurring. A really big mark of compulsions is if they are excessive and unreasonable. And while that can be very relative, what we know about OCD is that for a lot of kids and for a lot of adults who suffer, they often know it's unreasonable, and yet they still feel compelled to do it because there's still that big what if of what if I don't, or this distress is too much and I need it. And so they might know it's unreasonable and still engage in it. Common compulsions, a lot of grooming, hand washing, cleaning. Again, our pop culture OCD that we think of, kids who feel that they need to wash their hands over and over in a specific way. We have a lot of checking. I actually think that most compulsions can end up being categorized into the idea of checking, and there are specific kinds of checking behaviors that might be more overt. Going back to check if the door is locked, checking if the stove is off, checking to make sure things are unplugged, checking homework over and over again, checking to make sure that they put their homework in their backpack over and over again. We also see a lot of repeating behaviors that might not seem like overt checking, but are done over and over in a stereotyped fashion, needing to get up and sit down a bunch of times in and out of doorways. There can be a lot of different kinds of repeating behaviors. Mental compulsions are actually a large part of OCD that people might not be aware of, that kids might not articulate about. Mental compulsions are still behaviors, but they're invisible behaviors. There's ones we're doing in our mind. Prayers being said over and over, mantras being repeated, data mining or mental gymnastics, which is, reviewing things over and over to try and get that check of, did this happen? Am I bad? But ways of doing it kind of privately in their mind. The more overt one that I think is incredibly common for kids with OCD is doing that same check, that mental gymnastics, but with other people. And that's what we call reassurance seeking. Frequent, excessive reassurance seeking, even if the kid has already gotten an answer that has given them the information needing to ask over and over or in slightly different ways, or checking to see if the person who gave them the information is sure. We see that quite a bit. And another one is avoiding situations that might trigger the obsessions. So while this might not be one that happens after, what we see for a lot of kids is avoiding things that might trigger the obsession because they don't want to do the whole ritual. They don't want to have to deal with that feeling of it not being just right. And so we see that a lot with kids because a real big thing with distress and anxiety overall is people trying to avoid the thing, people trying to avoid the feeling. And so we see that quite a bit. One of the ways to think about OCD is to think of it as the doubting disorder. Not Freudian at all, but this is actually what Freud would call it. He'd call it the doubting disorder. When we're thinking about what does OCD want? OCD wants 100% absolute certainty to its questions, to those what ifs that we're seeing with our kids. When a kid has a what if question, their OCD says, we can't be 99.9999999% sure. We need to be 100% sure of what's going to happen. And the problem with that is that it's a fallacy to be 100% certain. None of us are 100% certain. We feel certain about certain things. Like today, I feel pretty certain the aliens are not going to come. I don't know when the aliens are going to come. I don't know if there are aliens, but I feel pretty certain it's not going to happen today. For a person with OCD, if their OCD happened to latch onto alien invasions, which actually has not occurred so far in my career now that I'm thinking about it, that 99.9999% feeling of certainty is not good enough. That OCD says, no, I want 100%. How can I get that 100%? I am not able to tolerate any sense of uncertainty, and I'm going to do whatever I can to get it, whether it's checking in any way, Googling, asking ChatGPT in every kind of way if the aliens are going to come today, asking mom over and over again, is that going to happen? Reviewing in their mind every alien movie that they've ever seen, anything that they can do to try and get certainty. But we never quite get there. We only get evidence. We never get proof. OCD doesn't care. It says, no, if you keep going, you might get that little bit that's going to make you feel better. And so it keeps going, and that's what drives the repetitive nature of it. Some examples from it. One obsession that can be a big one, again, coming back to that idea of harm that can come up, was that noise from me that I just heard in the park, me hitting someone with my scooter? I don't know. I can't really trust my memory because with OCD, sometimes there can be this pathological doubting of memory or sensory experiences, even. I don't like that. Like, it probably wasn't. I don't think that I did, but I don't like that uncertainty. And so the compulsion that follow is I'm going to go back and check to see if there's anybody laying on the ground. I'm going to ask mom and dad over and over, are you sure I didn't hit anyone? They're trying to reduce the uncertainty. But it's a fallacy because we don't ever really 100% know. And so it continues on and on. Obsession. Did my mom remember to turn off the toaster? Uncertain. We all pretty sure that we locked our doors this morning or turned off any appliances and we have a memory of it. But if OCD latched on and said, are you sure you can trust that memory? I'm going to go check with the toaster. I'm going to go ask my mom. I'm going to review that memory over and over to say, how do I reduce this uncertainty? But since we don't get there, and since OCD is intrusive, it keeps bringing the thought back. And so even if going to check the toaster, because we can go and check a toaster and see that it's off, that should be good enough, right? Should. I checked the toaster. It was off. Whew, I feel better. Great. I got my relief. I got my certainty. Now I'm in the other room. Wait, am I sure I really checked? Was the light off? Did I actually do it? Okay, I feel uncertain again. Last time checking made me feel better. Let me go do that again. And it goes on and on and on. Right? Uncertainty really latches onto important things. That's why uncertainty leads to high distress. That it's not just a toaster, right? It's not because we're just worried like, oh, what if the toaster's on? It's because worrying about big disasters, right? Thinking about how toasters being on can lead to fires. Same with all of our other topics is that the uncertainty tends to latch onto things that are really important or really highly valued for the person, right? And so It's going to cause high distress if you think about a toaster being on and starting a fire, or if you accidentally hurt someone at the park. Those are big bad things, especially for kids who want to do the right thing or are worried about people being safe. And so it leads to a lot of high distress. And so that checking leads to that momentary relief, but it's intrusive. It doesn't care that you just checked. It's going to pop in again and try and restart the cycle. And I mentioned about mental rituals, and I think it's really important to go back to because OCD can present with overt behavior, but also covert behavior. Overt behavior is typically what another person can see as OCD behavior. So we can see, the typical germophobia, hand washing and cleaning. We can see repeating stereotyped behaviors, going in and out of doors, flicking on light switches, tapping things a certain number of times. We can see superstitious behavior. We can see a kid who is refusing to walk on cracks on the sidewalk. We can see some perfectionism of somebody needing to rearrange their shoes over and over until it feels just right. Those are all overt. But there's a lot of covert behavior that we might not see. Engaging in mental rituals, repeating those mantras, reviewing memories. A lot of people in OCD world call this pure O, aka pure obsessional OCD, which is really a misnomer because what we're saying when we're calling it pure O is that we're not seeing overt behaviors. It's those covert behaviors. It's those mental behaviors that another person wouldn't see. And so it might look like pure obsession, but really there are behaviors, they're just private behaviors. Really important because approximately 23% of OCD sufferers don't have overt compulsions. And this is one of the big contributors to misdiagnosis or underdiagnosis, that they might not know that not every person is doing this level of data mining or mental gymnastics in their mind. They might think everybody else is doing this, and so they're not reporting like, oh, this is a thing I do. And parents aren't aware of it if your kid is doing it. They might look like they're just daydreaming or thinking about other things or getting stressed. And we don't know that there might be these covert behaviors underneath of going over things over and over. It's hard to pinpoint the exact prevalence in children because most studies of OCD don't really differentiate between mental rituals versus overt rituals. And so it's still important in terms of, taking them to a mental health professional with expertise to have them ask about any private mental rituals. Thinking about how this impacts our kids. Somebody who's going through this all day, we call them OCD sufferers because there's a lot of suffering. They're experiencing their little cortisol levels up all the time. They're experiencing a lot of anxiety and frustration. There can be feelings of isolation if their rituals or their fears keep them from being able to participate in certain things. It can make it really hard to maintain friendships or even make friends, particularly if they're always worried of what if I don't say the exact right word? What if I say this really scary word that I'm scared I might say without thinking about? Or, if there's have an OCD that has really, really specific rigid rules, it can feel really hard to have a friend who breaks those rules, even if the kid knows that the rules are unreasonable. It can be really hard if OCD shows up in school. It impacts focus. It can make it really hard to participate in certain activities depending on the content and what might be triggered because we have that compulsive avoidance, right? And it has a huge impact on families. I say with OCD, particularly with pediatric OCD, it's not just in the individual. A family is dealing with OCD. Parents are dealing with it. Siblings are dealing with it. It can lead to high conflicts at home. It can lead to high parental frustration, right? It can lead to that moment of, oh, just get over this already. Just stop asking me. And it can be a lot. And it can lead to a lot of accommodating behavior at home. Your kid is suffering. We're trying to do the right thing here. We're parents. We don't want our kids to suffer. And so we're trying to make it better, but it can allow for a lot of accommodating of the OCD, inadvertently aligning with it and doing things to make the OCD happy, but really feeding into the OCD. And that's why we call it accommodation. So, definition. Accommodation occurs when parents or caregivers unintentionally reinforce a child's OCD behavior by helping them avoid distress or to perform compulsions. Now, what's the problem here? The problem is it inadvertently reinforces the behavior. And it accidentally reinforces the parent. What I mean by that is that it reinforces OCD by telling the OCD, you're right, this is dangerous, I'll help you. I can see that that is a big worry and that is real. And so I am going to make it better by answering your questions over and over, making sure you have all the soap you need in the bathroom. I am going to help keep you safe because that's a real danger. So it accidentally reinforces the OCD. And the other moment is how it impacts our own emotions, how OCD trains us, right? Your kid is suffering, they're feeling all their feelings. We're feeling their feelings because we're good parents and we feel our kids' emotions a lot of the time. We're supposed to. And then there's that moment where even if you know that you're not supposed to give in to OCD, you do. You say, here, I'm going to help you feel better. I'm going to give you the soap. I'm going to answer your question. Your kid feels better. Ah, you feel better. The OCD trained you. See, if you give me what I want, I won't bother your kid anymore. And kids and parents and families can get really stuck in this cycle. So again, what's the problem here? It reinforces that OCD cycle by validating the fear, validating the compulsion. We inadvertently teach kids that they can't cope with uncertainty, that it's too dangerous. We'll help them. You can't sit with this. You can't handle this. I'll help you with it. Not in such a mean tone. It's that accidental message that comes out when we're trying to be helpful. And it teaches that emotions and worries are danger. That when the emotion comes up, when the OCD pops up, it's not a false alarm. This is a real fire alarm going off. And you can tell it's a real fire alarm because I'm panicking and I have to help you because I'm so worried about it. And it can really perpetuate the cycle. And not to be all doom and gloom, there are really good ways to be able to cope with that we're going to talk about. So we want to really encourage open conversations. We want to let kids know that it is okay to talk about their worries. Letting them know it's okay to talk about their worries does not mean having to problem solve them. If they start going on of like, I just get so worried about, what if I accidentally left the light on in the classroom and all the electricity goes out from the school? It's not a time to say, it's automatic lights in the classroom. You don't have to worry about that. It's just a time to say, wow, that's a really big worry thought, right? We don't have to problem solve. We have to listen. And that can really help encourage open conversations. We want to really externalize the worries. We want to talk about it as OCD and talk about it as this external thing that's bothering them. I hope everyone here went to see Inside Out 2. Great movie. I did a rewatch because it's finally on Disney Plus with my kids this past weekend. It's great because I have a metaphor built into my sessions now, although I feel like it's stealing part of my job because it did such a great job at externalizing anxiety. And a lot of kids have that language now. And the same can translate to OCD. And especially if you're in a place where it's not totally sure if it's OCD or anxiety, we can stick with anxiety. We can stick with worry in terms of externalizing, and it's still going to lay that foundation of talking about this thing that's bothering them. That's what we're talking about, externalizing. It's not them. It's their OCD. It's their worry monster is really bothering them about that thought. We want to avoid accommodating the compulsions. We don't want to reinforce the OCD, that we can listen and we can hear about the emotion, but we don't have to say, I'll call your teacher right now and make sure that the lights are off. We don't have to do that. That's accidentally reinforcing the OCD. The other side of it is trying to avoid criticism. It can be really hard I've answered this question a million times. I can't believe you're asking me again about it. We still really want to avoid the criticism because we want to avoid the shame and we don't want them to not let us know about what's been going on. Again, for those kids who might have more of the covert symptoms, we don't want them to be worried to talk about it because it can be hard to tell a therapist about it. And if you know about it, you can help facilitate that discussion. We want to validate the emotion, not the worry. It's really hard to be worried about that, not, oh my God, that will be a disaster. Validate the emotion, not the content. Find help. It can be really hard, I know that, but getting a diagnosis and appropriate treatment is the most important thing. A lot of parents get scared about labels, scared about like, I don't want to tell my kid that they have OCD. It really is, in my experience, that kids and adults feel so good to know that they're not alone in it, that this is a thing that has a label, it has a brain structure that explains it, and it has really effective treatment. In terms of resources, a trained mental health professional who has expertise in OCD. You can also get a diagnosis through a neuropsychological evaluation, a psychiatrist. So there's a lot of resources out there to get that diagnosis. Once you get the diagnosis, what's the treatment? So it's all in the name. Exposure and response prevention. Sometimes we'll see that as EXRP or ERP. So it's all in the name. Exposure. We want to do gradual exposures in this treatment to the feared obsession. So if that is contamination or scary taboo thoughts or really whatever the content is, we want to find a way to do gradual exposure and approach to those things that OCD is worried about. But more important than that, I'd actually say, is the RP, the response prevention or ritual prevention. We want to develop some tools and strategies for our kids to help them not perform the compulsion. Because if we do the exposure and then they're still engaging in the compulsion right after, we're accidentally actually reinforcing the OCD. So if I have a kid with my very stereotypical OCD of contamination and I have him touch a doorknob in our office and then he goes to wash his hands, it's not an exposure, right? Because he just went to do the ritual and he said, I can white knuckle this, but I'm still going to go do my safety behavior. I'm still going to let OCD win, and I'm still going to make sure that I'm trying to get that certainty. So we really want to work on the response prevention part as a big part of this treatment of how do we interrupt the compulsions? How do we find replacement behaviors? Even how do we ruin it? If a kid's going to wash their hands after they do it, can they touch the sink after? Can they go touch another doorknob after? So there's all kinds of ways of interrupting or ruining the compulsions. And what we know about interrupting this cycle, not letting OCD get that reinforcement of engaging in the compulsion, this reduces that anxiety that's linked to the OCD, and it decreases the behavior and makes OCD a much, much more manageable condition. And what we know from treatment studies is about 68% of children who go through a proper course of EXRP show significant symptom reduction. While this is the treatment overall for all sufferers, it's considered our gold standard treatment, we want to think about how we adapt it for kids. So a big thing is we want to normalize, we want to destigmatize. We want to call it OCD. We want to teach them about their brain. We have all kinds of fun ways of teaching them about their brain and their amygdala and their frontal lobe and all the other fun parts about their brain so that they can understand it as a brain hiccup. That's often the metaphor I use to talk about it, is talking about the hiccup in some of the connections between the back of your brain and the front of your brain. And so to know that it's not their fault, that's just how their brain works, and that we have some really great strategies to help it not bother them so much. We want to externalize that OCD. It's such an important tool. We name the OCD monster. Some kids like a clinical name. They like just calling it OCD. Some really like to give it kind of funny names. Some like to give it names that are specific to what they might be dealing with. One of my favorite ones is that I had someone whose OCD was really focused on what other people might be saying about them. And so they named their OCD Regina George, which I love. It's my era. It's my movie. So I loved talking about like Regina and what Regina was doing that day. We want to really talk about it as fear facing. We want to talk about bravery. I talk about the Wizard of Oz a lot and the Cowardly Lion, right? That he gets the medal for courage, not because he wasn't scared, but because he was scared and he faced the fear anyway. That's really where we're talking about bravery and courage. Or Harry Potter book 3, when all the kids have to face their fears and make them funny in one of the classes. I think it was Defense Against the Dark Arts. There's some really good metaphors out there in kids literature about thinking about being brave and facing fears. And we talk about OCD also as a bully, right? That it's really about, if a bully tells you what to do, you don't listen to them. And so we talk about breaking that OCD's bully's rules. And so we put it really into friendly kids terms. And even our adolescents like some of this, even though some of them might roll their eyes at me too. And another big thing is that we involve families. That even if a kid is in individual therapy for OCD, we want their parents involved. We want their parents helping them practice at home, and we want the parents working on those accommodation cycles that might be happening even while they're in therapy. Another evidence-based treatment for OCD is SPACE, which stands for Supportive Parenting for Anxious Childhood Emotions. And the focus of this treatment is reducing those parental accommodation cycles in a supportive way. See, it's always all in the name. We want to do it in a supportive way. We're not just going to throw them in the deep end of the pool and say, we're taking away every accommodation ever and just deal with it, kid. Nope, we want to do it in a supportive way. We want to do it while showing empathy for the feelings that they're having. Their feelings are real, while still setting limits on how much parents and families are engaging in those compulsions. And again, this is another evidence-based treatment that shows really similar effects to individual therapy. About 60 to 70% of kids whose parents go through this treatment show a reduction in symptoms. And it's a really great treatment, especially when kids are resistant to direct participation in therapy. You know, for kids who have that resistance, sometimes some really great motivational work can help them get involved, but some kids, it might be a non-starter. And so it can really, really help in those situations where a kid might be resistant or might have other reasons that individual therapy is not a good fit for them, that this can do a lot in terms of helping a lot of families. Oh, I got to check on my time. I think I might be going too fast. No, I'm doing good. All right. So medications. So in terms of medications for OCD, I'm not a medical provider. So I can't actually say like this is the exact treatment for a kid. But in general, what we know is that SSRIs and some other medications are often the ones used to help manage OCD symptoms. Medication can be effective when symptoms aren't getting better after a good try at EXRP, but therapy is still the first line treatment. We should go with good EXRP or SPACE first before going to medication. But it can help when the therapy isn't enough, when we're kind of playing whack-a-mole with different symptoms and we're not seeing that overall improvement in functioning. So, in terms of some strategies for home, one of the things we want to think about is we want to set really clear limits on the compulsive behaviors. What are the boundaries that you're going to hold on OCD related rituals? Which might not mean that you can tell your kid, you can't wash your hands anymore. I'm saying that right now, but saying about what you will or won't do. Maybe you won't provide any more soap. We want to use a gradual approach to it because we're not just throwing kids in the deep end of the pool, and work with an OCD specialist or a SPACE trained professional to help make a plan of how you can do it gradually and how you can do it in a supportive way. We want to stay calm and supportive, Zen neutral. When they're distressed, we feel they're distressed. It's easy to get caught up in their distress or even to get frustrated. We want to stay calm, neutral, while empathetic. I really know that this feels really bad and I know you can handle it. That's our supportive statement. The emotion is real and I believe in your ability to get through this. Not, and I'll help you problem solve it. And you can do it. Just get over it. You can handle this tough emotion. That's really planting the seeds for distress tolerance, about being able to handle all different kinds of emotions that come up. And you can also use positive reinforcement at home. Everything from really praising any kind of baby steps that they might take about facing fears to thinking about setting up for brave prizes for them being able to face fears. We want parents to stay really involved in treatments. This is definitely not a drop-off therapy. This is one where you want to be involved. You want to know what's going on. As we get into the teen years, sometimes there's some concern for privacy depending on content, but the general principle is that you want to be involved in treatment and you want a therapist who's helping you know what you need to be doing at home as well. We want to avoid our reassurance giving. It's really hard. It would be so easy to just answer the question and be done, but we want to really think about giving information, not reassurance. Somebody asks a question, you can give the information. Somebody asks it again, it's reassurance. Another great thing is to just really think about encouraging independence. Encouraging independence is another way of encouraging bravery, encouraging facing fears. And so thinking about how you can encourage them taking small steps towards facing a fear, helping them take small steps towards facing down that OCD monster. these are going to be in the slides, so I'm not going to read them through so we have time for questions. But here I have listed some books for parents that can be really, really helpful in terms of understanding OCD or some strategies for home. I have some books for children. I'll give a particular plug to What to Do When Your Brain Gets Stuck. I've worked with a lot of families who found it incredibly helpful. I have some media resources listed down below. Unstuck is a great movie that a lot of kids feel really connected to when it comes to understanding that they are not alone in OCD. Anxious toddler parenting community. Really should have spelled that out. At is kind of hard to Google. Natasha Daniels, she has a great YouTube channel, podcast, has a whole community for parents of young kids suffering from OCD, including toddlers. So it's a great resource. Flusterclux is a great podcast. I think the tagline is for parents who worry about kids who worry. There's a lot of great stuff about anxiety and some specific stuff about OCD. And it's really aligned with an exposure / space kind of framework of thinking about OCD. In terms of finding help, IOCDF, the International OCD Foundation, has a provider search that can be a good starting off point. NoCD is an app that just focuses on providing exposure and response prevention. They do take insurance. It's all virtual based. It's treatmyocd.com. And Space Treatment, you can go to Space Treatment's website and also do a provider search. And generally, if somebody's trained in space, they're probably trained in EXRP. So, that can be a resource even if you're looking for individual. Okay, I think I left some time for questions.
That was awesome. Thank you so much, Becca. Yes, okay, so we have a few questions already, and anyone who has a question but hasn't asked it yet, please feel free to type it into the Q&A box. So one of our first questions is about how... Yeah, go ahead.
Should I stop sharing my screen so I can be big? Is that better?
Oh, sure.
Or leave it up?
Yeah, go for it.
Okay.
No, go ahead and stop sharing.
Okay.
See our lovely faces. We know that OCD has a high genetic loading. If you have a family history of OCD, kids are more likely to have it too. And so one of the questions is there anything that, say you have a family history of OCD, that is a higher likelihood in your kids. Is there anything that we can do to prevent it from happening or keep it from getting very impairing?
So because OCD has such a high genetic loading and a high biological basis, there might not be anything we can do to prevent it 100% from happening. It might pop up when it pops up, but we can really encourage kind of exposure lifestyle framework, right? So if you know that it's something that runs, really thinking about talking about facing fears a lot. Really, like going to the amusement park and being like, ooh, that roller coaster is making me feel really nervous. But the fact that it's making me nervous means I should probably do it and see how it feels. Right? Or, you go to a restaurant and it's like, ooh, that's a food I've never tried before. And that makes me a little nervous because I don't know what it's going to be like. But you know what? I'm going to face that fear. I want to find out. And so really thinking like exposure lifestyle sounds a little cheesy, but it's kind of fun to think about, is thinking about, talking about like when something scares us, let's try it. Let's find out what's a real alarm, what's a false alarm. Let's take a little risk. And it can be hard because when we're talking about genetic loading, sometimes we're thinking about a grandparent who might have had OCD or a sibling, and sometimes it's the parent itself, right? And so, if a parent themselves is working with OCD or suspects that maybe their anxiety might be OCD, it can be really helpful to work with somebody for yourself too, to talk about, exposure on your own and facing your own fears too, because a lot of times it can kind of get a little mixed up too, right? Like a parent who has OCD might get really, really worried of like, what if this is the sign that my kid has OCD? Right? And so they might want to work with somebody who has that training to help work with facing that fear too. But we really want to think exposure lifestyle, face the fear. And I come back to also encouraging independence, encouraging a little bit of healthy risk taking, right? Encouraging a kid that they can go to the next aisle in the grocery store, even if it's a little bit uncomfortable, having that trust and showing them that faith that they're going to come back. Plant that seed. We're thinking about planting seeds about facing fears, and that it doesn't mean I'm not afraid. It means that I'm afraid and I can do it. I'm afraid and I can
Right.
handle this feeling.
Right. And I think that it also helps to combat the what ifs as well. The more
Hmm.
experiences kids have, the more that they learn to, think about things in terms of the probability of this happening is pretty small, and I can handle the fact that I don't know 100% that it's going to be okay because I did it the other day. Um,
Hmm.
we at Small Brooklyn have been talking a lot about the anxious generation and about ways of
Hmm.
improving, just exposing kids to more life experiences, more independence projects, more
Hmm.
self-reliance sorts of activities. And so the more they get out there and, like you said, take risks, the more that they're going to learn that, hey, this is something
Yeah.
that they can do.
Yep. I'm
Sweet.
working with a young adult right now. And we are working hard on her and her family disabling tracking
Oh,
as part,
that's a big one for sure. Right. What
it's
if
a
this
lot of
day that I don't
uncertainty
have
checking.
on the parents' part, right?
And
What
it's
if
a
this is
tough
the day that I
one.
don't have it and this is the day that she gets kidnapped? Yeah, it's
What
it's
if the
hard.
aliens come?
Well,
Hmm.
good point. Good point.
It could happen.
Um, One person asks, is there a connection between OCD and phobias?
So Oh, I wish I could ask a follow-up question about what they mean. So in terms of treatment, we're going to do the same treatment. We're going to do exposure treatment for both. And so with phobias, what we're going to see more is an utter avoidance of that exact stimuli, whether it's needles, always a fun one, dogs, spiders, bugs, whatever, making sure that they avoid it at all costs. In terms of repetitive behaviors outside of kind of making sure that they're avoiding it, we're going to see that less with phobias. And the other thing about phobias versus OCD is that for a lot of OCD, a kid will have a fear and they'll kind of know it's unreasonable. But with phobias, a lot of times kids are like, nope, this is reasonable. I really don't want that needle.
Yes.
No, thank you.
Yeah.
As opposed to, with OCD, it's like, I know that it's like a pretty small shot of, getting HIV from this toilet seat, but like I just can't take the risk.
Good point.
So I don't know if
And
that has
then
answered that person's question, but yeah.
um original poster, if that did not answer your question, please feel free to ask a follow-up question. I'll try and get to it.
Mm-hmm.
But in the same realm of distinguishing OCD from other things, people are asking about distinguishing between tics or other
Mm,
sorts of, sometimes like autistic calming rituals. Is there a way to be able to
mm-hmm.
tell these kinds of ritualistic behaviors versus OCD compulsions?
Yeah, and it can be difficult because when we're distinguishing it, we're really thinking about the function of the behavior. And, there is a pretty big overlap for kids who have tics and OCD as well as with autistic kids. And so it can be difficult to sometimes really fine tooth comb between them. And so when we're looking at them as professionals, we're thinking about what's the trigger to them? Why are they doing them? And that's what I mean when I say function. And so for tics, they're responding to a physiological sense that occurs right before. We call it the premonitory urge. And they're getting relief from that physical urge for the tic, as opposed to OCD, where repetitive behavior is in response to distress of an obsessive intrusive thought, right? As opposed to, for autistic kids, a lot of repetitive behaviors that might be self simulation might be actually just used for like soothing sensory experiences. So it can be really tough. One of the things that can help a lot of the times with OCD is that if it if it feels like a kid is like, I know I should stop, but I can't.
Yeah.
Although, with tics, it can also be involuntary, but it almost is that they sometimes are not even aware that they're doing it. With compulsions, they're aware of they're doing it, but it still can have this sense of being involuntary.
Hmm.
And the treatment for tics is habit reversal training or comprehensive behavioral intervention for tics. And while there are some same messages in terms of some parts of EXRP, it's a pretty different treatment too.
Cool. So always good
That
to
could be a
reach
fun
out
talk.
to providers, yep, to help you distinguish and figure things out what to do next.
Mhm.
Okay, lots of parents who are interested in how they can remove accommodations and support kids that way. So One parent says, should we forewarn our child that we are stopping accommodations, removing one at a time, and reassurances, repeated questions?
So in these talks, I try to never give direct advice because there's things in our ethical guidelines about it. So I'll say in general, what I tell families is absolutely tell them you're doing it, tell them why. And what I mean by tell them why is not saying like, you've been doing this too much, so you have to stop it. No, I realize that my behavior is not helping. It's actually making things harder for you. And that's why I'm deciding this. And it's not making a demand on their kid that they have to do something different. It's saying, I am stopping my behavior because I've realized that I'm not helping your worries. I'm not helping you feel better by doing it. And so, absolutely forewarn, one step at a time. The best kind of plan in reducing an accommodation is one you can stick to. So it doesn't
Mm,
have to be reducing absolutely everything. If it goes from, I'm not going to provide 8 bottles of soap a week, I'm only going to provide 6. If that's what you can stick to, fine. Because you want it to be something that you can stick to so that if you tell your kid, I'm not going to do this anymore, they understand that that's real and that if you say it again, it's going to be real again.
hmm Sweet. And then another parent asks, when they ask the same question repeatedly, what is the kindest but not accommodating response?
Mm-hmm. So give that forewarning, piggybacking off the last question. If this is something that's happening a lot, one thing that I often tell parents is letting kids know, I'm only going to answer this once, especially if it's something you know that they're going to ask all the time. Are you going to be there early at school today? If you know that that's going to be a series of 20 questions, the first time they ask, you know it's going to be a series of questions again. So start off with the forewarning of, I'm only going to answer this one time.
Mm,
And then they're not going to take that. They're still going to ask a bunch of times, right? Their OCD wants them to ask. They want that certainty. And to be able to say after that, I know that it's really hard that your OCD really wants me to answer. I know that that's really tough. I know you can get through it. I've already answered that question. You're done. You don't need to repeat that a million times every other time they ask. It's okay to disengage. You don't have
okay,
to add oxygen to OCD's fire.
sounds good. Um, we are at time, but I'm going to go over just a couple of minutes so we can answer a few more of these questions.
Sure.
A parent is wondering if there are some basic responses that she can use when a child is paralyzed by OCD in the moment.
Mm. So it depends on age too, right? Like a really young kid versus a teenager can be really different in terms of thinking about like what that being paralyzed by OCD is. And so, for the younger kids, if it really is totally stuck, totally frozen, I go with distraction. Start doing other
Mm,
stuff, start talking about what you're doing that's totally unrelated to it. Because sometimes with OCD, it does need to go through a wave. It needs to peak, it needs to come down. And so
mhm.
trying to get somebody out of it when they're stuck is going to make that peak actually go higher,
Yeah,
right?
similar
We
to
need
a
to let
meltdown.
them ride the wave of it a little bit more. Exactly. And so, some of it is when they're younger, distraction, even a teenager, just start talking about what you're making for dinner. They still might roll their eyes at you, slam a door, but they might do that if they don't have OCD anyway. Um, right? Like interrupting a meltdown, think of it as OCD is having the tantrum.
Hmm.
We can't
Fair.
force OCD to stop. And so sometimes it is the riding the wave. Sometimes it is being able to come in with that supportive statement to say, like, I know this is really hard. I know you can get through it. Hey, do you want to help me bake cookies?
Mm, sweet.
Right? Don't say
Okay.
that the feeling's not real. Don't say that the worry's not real. Say that the emotion is really there and here's something else.
Awesome. How do we manage OCD rituals that are impacting sleep? We have a kid that has anxiety about not getting a good night's sleep and has rituals that end up delaying her from getting the sleep that she needs.
Okay, so this is like where it combines into like OCD and a little bit of insomnia worries, right?
Mm,
I'm worried about not getting sleep, and what we know about insomnia is worrying about not sleeping really makes sleep really hard. Um, Again, with the caveat of like work with a professional on this, you can come up with it because if this kid were in my therapy office, we would work on doing some scripts about not sleeping, practicing staying up all night, right? Face the
Whew.
fear.
Yeah.
Face the fear, building up to it, gradual, supportive, all of that kind of stuff, but really thinking about it. And also, if a kid is saying, like, what if I don't sleep? What if I don't sleep? Say, maybe you won't.
Mm.
I know that sounds really counterintuitive, right? Like, we want to give our kids comfort, we want them to sleep. They're not going to not sleep for the rest of their lives. Definitely by college, they'll get to sleep. We have time, right? And again, adapting for EXRP for kids, we need this kind of humor with it. But
Yeah.
sometimes what it does, particularly at bedtime, is it gets into the back and forth with families, right? Of like, well, what if I don't sleep? And then it gets into a big discussion, and all of that back and forth is fuel for OCD. It wants to
Mhm.
have a back and forth. It wants to keep playing tennis with all the good logical points that you're making. And so the way of not playing is saying, maybe you won't sleep. I guess we'll deal with that tomorrow.
Mhm. Awesome.
Probably really
Okay.
scary to the original poster to think about it, but I'm
Oh,
making you
I'm
face your
sure.
fear and thinking about it right now.
Right. Okay, one last question. What is the difference between 4-year-olds asking the same question over and over and having OCD? Is it too young to consider this OCD behavior or anxiety?
Like all other answers in psychology, it depends. Um,
So
this is, I
satisfying.
think, true of like the five and under crowd, is that there are a lot of things that are completely developmentally normal for the five and under crowd that could also be OCD. Who hasn't met a 2-year-old who loves washing their hands? Right? My nephew wouldn't
So
stop
do
washing his
mine.
hands for like 3 weeks. He definitely doesn't have OCD. Well, my sister's not mad I'm using it as an example. He just loved it. He loved it when he was 2 years old, right? And so it can be really difficult. And I think one of the things to think about is your 4-year-old asking for a lot of information or a lot of reassurance? Are they
Mhm.
asking about sharks over and over because they're trying to learn everything about sharks and because they still have goldfish memories and they literally did forget that you just explained what a whale shark is 2 minutes ago? Versus, is it, am I safe kind of
Right.
questions, right?
Yeah.
Like, think
What's the
about that
function?
emotional component, because kids can do a lot of repetitive questioning. Like, my kid needs to stop asking me to take the back off the toilet so he can watch how the water works. He asks me every night how the water works. That's not OCD. He's very curious, right? But if it was, is the water going to go down and what's going to happen if it doesn't go down, right? That's the am I safe kind of reassurance seeking. And that's where we get more concerned about the potential of OCD.
Sweet. Thank you so much, Rebecca. I really appreciate hearing all of your expertise. And thank you to everybody who joined us today and everyone who's watching the recording. Park Slope Parents, thanks for having us again. And please watch out for future webinars. We will have more as the year goes on. And feel free to reach out to us directly if you need more individual help. Bye, everyone. Have a great day.